It is now my pleasure to introduce Peter Lee, Executive Director for National Health Policy with the Pacific Business Group on Health. Mr. Lee oversees the efforts of PBGH to shape national and state policies, to reinforce purchasers' efforts to improve the affordability and accessibility of high-quality health care. He represents the perspective of purchasers seeking to promote high value in health care by working on California national policy and quality reform efforts. Please join me in welcoming Mr. Peter Lee.
Thank you very much, and it's a real pleasure to be here. That was also a great set of opening remarks that really tracked so closely to the national priorities that I'm going to be talking about. As Bob noted, I'm from the Pacific Business Group on Health in California. We represent very large purchasers of health care, Wells Fargo, Intel, Chevron, et cetera. But we do a lot of work nationally on policy issues. And in one of those capacities, I served on a group called the National Priorities Partnership, a partnership of 28 leading organizations representing employers, consumer, labor, physicians, hospitals, trying to identify common priorities that we could work on together. And what I'm going to do today is to walk through those priorities, but I do want to reiterate a couple things about those P's that we heard a moment ago, is that important P of working in partnership, that important P of the patient. But also, when we think about partnership, it is so important that we aren't talking at each other, we're talking with each other. And it's one of the things that Bob said that is so important. And I'm going to be talking both about the National Priority Partnership goals, and for those that didn't see it, there's the full report that's in the back of the room that you can have for nighttime reading. But I'm also going to be talking to you about how this is seen from an employer perspective and trying to put this in some of the context of what's happening with national health reform. So with that is what are the overall national priorities that have been set by the National Priority Partnership and are now being looked at by CMS, by the administration? They're basically 6 overarching objectives. And I'm going to come back to these, but I want to sort of frame these as I go through everything else. They're first, to engage patients and families. And I think it's so important when we talk about healthcare, being patient-centered is a core goal that we need to be driving for everything we do. Second, improving the health of the population. Third, improving safety and reliability. People shouldn't be getting sick in the healthcare system because of the healthcare system. Fourth, ensuring that patients receive well-coordinated care, that the handoffs are there, they happen well, they're done right. Fifth, that people at end of life get compassionate and appropriate care. And finally, that we eliminate waste. Those are the 6 priorities. They're driving efforts around the country. But I want to now, I'll come back to each of those, but I want to frame some of where these fit. Now, I noted that I'm represent employers. So when we look at the healthcare system, one of the first problems that you're familiar with is rising costs. And this is a slide that was developed by Peter Ortzag, who is now the head of the Office of Management and Budget, part of the Obama administration team. This notes that if we keep on going at our current rate of spending, healthcare will take up half of our GDP, the entire domestic product, half of it, by the time our children are reaching Medicare age. Now, some of us won't make it to Medicare age in 2082, but our kids will. Clearly, this is unsustainable. We cannot have rising costs as they've been going up. We have to address it. It's a huge problem. Second, many of you are familiar with the report called the IOM report on To Err is Human. That was a report issued 10 years ago, noting that we have problems in how we deliver care. It also noted, shortly after that, crossing the quality chasm, noting that we have quality failures in the American healthcare system. Now, this is a busy chart going on, but there's a couple things that this tells a few stories about. The upper left-hand corner shows the charts on how often do we provide the right care at the right time for things we know how to do. Now, RAND has documented repeatedly that we actually hit right care the right time about 50%. That's not nearly good enough. And when you look at how that breaks out, it means for a woman with breast cancer, the likelihood of her getting the right care, the full spectrum of what we know how to do, it's about 75%. And that's the best. If you look at areas of ulcers, hip fractures, it's more like a quarter of the time are we doing all the right things. But you also look at where are we with life expectancy in the U.S. We're 10th. We're 27th on infant mortality. Hearing from Dr. Remley is an important reminder where we are looking at issues of infant mortality. Avoidable harms in hospitals. 100,000 Americans die each year from avoidable hospital-acquired infections. This is clearly central to why we are all here today and the work you're doing, which I absolutely applaud. Finally, though, in terms of part of the chasm we have is overspending and waste. If you look around the country, and there have been study after study that have looked at where we spend more does not mean we get better care. If we spent the same amount of money in the states that do a good job providing care consistently across the country, we could save $700 billion. Now, a few years ago, that sounded like a lot of money. Now we think, oh, that's a stimulus package, but it actually is a lot of money. That's about a third of the healthcare budget. So that's our challenge, but the good news is we know we can address that challenge. And we know in a number of cases that, for instance, I'm sure many of the hospitals in Virginia are participating in the 5 Million Lives campaign. We know through those efforts that hospitals are proving you can get to 0 infections. We know that some states are delivering care far more cost effectively than others. Utah's an example, if you're wondering what that little boxy state is. Again, if care was provided as it is to about 4 million Medicare beneficiaries, we could save about a third of Medicare spending. We know we can reduce mortality from heart disease. Kaiser in Northern California reduced disease mortality from heart disease by 30% in 5 years. We know that health plans working with providers make a difference. If all health plans in the country provided care as effectively as did the best 10% accredited by NCQA, we would save 40,000 lives and over $2 billion. So we know there's a path we can go on. So how's this fit in national health reform? And again, this is an area that I'm mainly talking about the national priority partners, but I want to give you a context of that. And I want to start with a little bit of a pogo. Many of you know the expression from the pogo cartoon, I've met the enemy and he is us. This is all of us. Speaking from an employer perspective, very often when we look at reform, we start by playing what I call defense, which is whatever you do in reform, don't affect us because, boy, our life is really tough. And employers talk about things like, don't mess with the employer-based system, which I agree with. Don't mess with ERISA, don't tax us differently, don't have mandates, etc. But I want to put you in your shoes because very often if you're representing physicians or hospitals or a pharmaceutical company, device manufacturer, unfortunately, you will start from defense, which is, yes, we need to change the system, but that means changing you other folks while I don't change. What we all need to do, and I think what the National Priority Partnership goals give us a pathway for, is to move from playing defense to playing offense, to changing the healthcare system by looking at how do we align the public and private sector. How do we look at a healthcare system, which is an entire system, not a Medicaid system and a Medicare system and a commercial system? How do we make sure we know what works? How do we measure healthcare? How do we look at comparative effectiveness research so we actually have tools for improvement? How do we change payment to align payments to actually reward better quality? How do we get consumers with tools and information to make a difference in their lives? And finally, how do we invest in prevention and wellness? Those areas which I think are for employers, areas of what I call offense, are not saying let's not change the system, are central to delivery reform, are central to actually addressing costs, and you'll see as I go through the National Priority Partnership goals how the National Priority Partnership goals provide in many ways a roadmap for moving to offense and changing the delivery system. So when we look at the big goals, where do we stand today? Generally, before the National Priority Partnership formed, which started in 2008, we had lots of public reports out there on a lot of different issues. We had many groups developing reports, and we had a lot of groups doing different actions. And I think one of the things we've seen clearly here in Virginia is when you come together to work better and align things, you can go further and faster. What we're seeing nationally, though, is this disparate range of actions meant we were not progressing very quickly. We were moving slowly on improvement. One of the ARC studies said we're improving care at about 1.5% a year using a range of measures. I'll note, sadly, the most recent report from ARC on national healthcare quality noted actually we're about flat. We aren't improving. Problem. We are not coordinating our efforts. We are not working together. We're not addressing the known problems. So why do we need national priorities? We need priorities to focus what we're doing, to align efforts across different sectors, across payers, across purchasers, across physicians, across hospitals, and we need to accelerate dramatically the areas of improvement. So that's why we need national priorities. So the National Priority Partnership, believes that the difference we can make by having common priorities isn't about here's something new to measure. It's about taking action. And by having common priorities, we can first know what we should be measuring, which is where are we falling short? But from that, drive action. And drive action that should be actions taken by every single stakeholder at the table. We should change how we pay for care to push for these priorities. We should change quality improvement programs on the ground, at the bedside. We should be giving better tools to consumers. And so when you think about the National Priority Partnership and think about the 6 priorities, don't think about them as abstract goals. Think of them as a roadmap for action. So I noted that there was 28 of us representing a whole range of groups. We came together and met for a year to identify high priority goals. And we did that by saying, what are the main things that should focus our attention? And we looked at 4 major criteria. First is eliminating harm. Second, reducing disease burden. Third, removing waste. And fourth, eradicating disparities. And again, I need to tip my hat to Commissioner Remley, noting in the area of infant mortality, there's real problems with disparities in care in America. Some of it we don't understand, but shining on the light on it and making sure we're asking the question, why do we have inequities in care, help us address the problem. In doing that, we looked at the sweet spot, where there was overlap, to identify high impact areas. We identified the 6 areas that I noted before: family engagement, patient engagement, population health, and I'm going to walk through each of these. But again, I want to note that in all of them, come back to think about that P of the patient being at the center. And all of these are about the actions that we as stakeholders, cutting across a range of sectors, can take to address these priorities. So going through each of these 6 areas. First, patient and family engagement. And for those of you who have the printout, these are, I shifted the order a little bit, but you've got the background slides there. Is patient and family engagement. What we've known is that patients want to be engaged in partnering with making decisions about their care, and far too frequently they're not. If you ask patients, 96% say, I want to be a partner in making decisions with my physician about my care. When we looked at that with the National Priority Partnership, we saw that in many ways as the first goal of engaging patients with their family in managing their health and making decisions. What does that mean in terms of focusing? First, we need to be measuring patients' experience of care. And one of the things I think is a big advance on the hospital setting of having now standardized hospital patient experience measures is a great advance. We need to have the same level of patient experience, asking patients what their experience is in every setting with all providers. We need to engage patients in self-management, giving them tools so they can be helping managing their own care, and we need to engage patients in shared decision-making. What's the right decision for them? There's not right care globally. There's right care for each patient that needs to be engaged in making those decisions. Second priority area is population health. And again, Dr. Remley noted this in a couple areas of noting the challenge we have in America with obesity. This is not just a Virginia problem, it's a national problem. We have problems with immunizations, and it's a huge gap. When we look at improving the health of populations, one of the things we recognize is that this isn't just a health care issue. This is a community issue. Issues around healthy lifestyle behaviors are issues that employers understand well, and many employers have put in place significant initiatives focusing on promoting wellness in their workplace. But they know that their workers leave the office. And if they go into communities where there isn't a place to exercise, where schools no longer have physical education programs, where there's not fresh vegetables in the local markets, everything you do in your workplace is going to be for naught. So we need to have focus on promoting healthy lifestyles. We need effective preventive care. And one of the things we identified is a need for a community index to assess health status. Let's look at how Richmond is doing in promoting health and wellness, because it's not an issue just of the healthcare system. It's of the community. And one of the things we're working on nationally is creating that community index so each community can see how they're doing compared to other communities and can have a better benchmark going forward. Third area is safety. Now, the good news is this audience is one that has rolled up its sleeves to address this issue in a big way, has recognized that we need to improve the safety and reliability of America's healthcare system, and it's what you're here for today. It's what many of you work on all the time. You know the reality that we have almost 2 million Americans that have healthcare-associated infections. You know the problem with drug complications. You know the problem with wound infections. These are areas that the nation needs to focus on. It needs to shine the light on it, both of affirming the good quality improvement work you're doing, but also to hold ourselves accountable to show how we're doing, to make public information around healthcare-associated infections, to make public so patients can be engaged in their hospital about asking their clinician, I don't think I saw you wash your hands. To engage in how do we reduce serious adverse events. A critical area that I think is important for engaging the trust of Americans, but also an area we know we need to improve in. Next, care coordination. All too often, we don't do handoffs well. We can get very effective care in a hospital and discharge a patient to no one, to patients who all too often don't talk to anyone when they've been discharged. You've seen a lot of attention in this area in the budget discussions recently of looking at how Medicare is considering doing payment changes to address readmissions. There are a huge number of readmissions that are absolutely avoidable with better handoffs being delivered from the hospital and received from the physician, the outpatient setting. Some of the areas we need to look at here reflect making sure we have medication reconciliation. Do patients know the drugs they're walking out the door with? Do the doctors outside know the drugs that patient has been given inside? Are we addressing, again, preventable hospital readmissions? Are we looking at people going to the emergency room when they shouldn't be? Again, these are all areas that have the opportunity for action across stakeholders, and it's a critical area we should be focusing on. Next is palliative care. Often, we avoid some of the tough topics. It can be tough to talk about end-of-life care. It can be tough to talk about what you do in that last weeks or months. Not talking about it, though, means we have millions of Americans who are dying in ways they would not want to die. They're dying in hospitals, getting interventions that, if asked and engaged, that is not where they would want to be. They'd want to be in hospice, they'd want to be at home, they'd want to be engaged in how they go through the last weeks and months of their life. Making sure that we have a healthcare system which engages patients in getting compassionate care for those with life-limiting illness is a critical national priority that, again, we need to shine the light on because it's a tough topic. And people will talk about it, they want to talk about it, but if we don't have the courage to step forward and say, what do you want to have happen in those at the end of life, we don't give the opportunity for patients to fully participate in some ways, the most important part of their healthcare system, which is at that end of life. We need to make sure we are relieving physical symptoms, that palliative care is being delivered, that people are not in pain. We need to make sure that people's spiritual, psychological, and social needs are met. We need to make sure that there's an opportunity for hospice care, that there's an opportunity for care that isn't anchored necessarily just in the hospital. And we know that today about 30% of Medicare spending is at end-of-life care. We know there's a lot of waste there. We know that there's a huge number of people that are dying in ways that don't meet their needs. Finally, the sixth goal is to reduce overuse. And this is one that I really need to take my hat off to the physician community that were part of the National Priority Partnership. I noted at the beginning, often we've met the enemy and he is us. We sort of point our finger elsewhere and say, oh, you're the problem. You payers that don't pay enough. You hospitals that aren't focusing on problems, et cetera. We had, amongst the National Priority Partnership, leaders from the AMA, from specialty societies, that says, we have a problem with overuse. We have a problem with waste because we are not delivering appropriate care. And we know in America we have problems with underuse. We are not delivering preventive care when we should be. But to have the physician community step up and say, we recognize we have a problem with overuse. And part of addressing the overall national healthcare crisis means we have to address the problem of overuse. Areas of focus are to look at inappropriate medication use, inappropriate lab tests. Are we doing too many of them? Unwarranted maternity interventions. Again, I don't think Dr. Remley looked through all my slides ahead of time, but noting the problem here in Virginia with C-sections. There's too many C-sections happening across America. This is not just a Virginia problem, it's a national problem. Now, that doesn't mean there shouldn't be some C-sections. There shouldn't be some induced labor, but the rates are too high. And one of the things we need to do for every one of these priorities is to focus on measurement so we can help patients and help their doctors say, what's the appropriate level? When should this be happening? When shouldn't it be happening? But it's happening, in this case, in the case of C-sections, far too much. We're doing diagnostic procedures far too much. All too often, we have issues where someone has a low back pain, and the first thing we do, send them to the MRI. That shouldn't be where we start. We should be starting with physical therapy. But we have too many procedures happening for diagnostics because all too often, and I want to come back to payment, that's what we reward. We don't pay well for physical therapy. We pay a lot for an MRI. So back to aligning incentives is going to cut across all of these areas. Preventable emergency visits, I noted, non-palliative services, end of life. Often, again, we intervene too quickly. And often we have preventive services would actually may be harmful. We often can do too much. The thing that I cannot say enough, though, is that this is not an issue of the evil employer coming along to doctors and saying, practice care differently. This is an issue of the cardiologist stepping up and saying, we need to look at who should be getting stents, who should be getting cabbages, are we doing this enough, or are we doing this too much? And let's start measuring by the guidelines and where we're outside of guidelines. This is having, again, the clinical community stepping up and holding themselves accountable for overuse. So where does this go? Well, I noted that I'm an employer, I represent purchasers, and I want to look at actions from two perspectives. One is from a perspective of employers, and the other from broadly looking at collaboratives such as are represented around this room today. Employers look at what we often call value-based purchasing, which is not just saying, here's the money, shoveling it across the table, but also not saying that we're going to try to drive our employees to use less care. Rather, we want to use our purchasing to encourage our employees to get the right care, the right place every time. How do we see that as value purchasing? It starts with performance measurement, of measuring the care in every setting, providing that information to consumers. It means aligning our payment with value, which is something our healthcare system does woefully badly. It means public reporting, because again, we believe when we look at value-based purchasing, a key element of changing healthcare is the patient, and it's giving him or her information to make better decisions. So that means taking that to actually providing tools for the consumer engagement tools. So that's the purchaser and how we're looking at these 6 goals. What do we do to align them? We look at those levers. What does it mean for others of you around this room? It means, well, changing overuse, changing the culture in a hospital and changing what we do around patient safety means we have to have other systems in place. They're having the technologies in the workforce that are focused on these issues at the bedside. It means quality improvement initiatives that, again, you're going to be hearing about later today and are the focus of many of your collaboratives' work. It means research. It means better information on what is overuse. You know, we can get in discussions about, you know, a stent may be put in. Is that the right stent or the wrong stent? We need better research to identify when it should be happening. And finally, strategies with regard to accreditation and certification. Is how do the tools that hold either individual providers responsible for their professional responsibilities through certification programs or accreditation programs help reinforce the movement for these common goals. And it's critical, again, that it's not an issue of having goals for one sector. It's having goals that cut across purchasers, providers, plans, and professionals. So why bother, and where's this go? Again, looking at this from a purchaser perspective, we see that what we can do is help create the drumbeat for these common, important, critical goals. And that means we have our members, and it's one of the reasons I'm so thrilled to be here to engage the purchaser community in Virginia in learning about these priority areas. That same thing is essential, though, if you're representing a hospital, you're representing a health plan, you're representing a pharmaceutical company, is learning about the priority areas. For an employer, the place we start is looking at our purchasing. You know, we actually don't want to get, so to speak, in your business if you're a provider, but we do help drive the money. In doing that, where is our purchasing not aligned with these goals? For instance, when we look at our benefit design, do we not cover hospice care? You know, if we don't, all of a sudden, there's a big barrier to addressing one of the major priority areas. When we look at our payments, as you know, last year CMS embarked on a system of non-payment for errors. Well, what are we doing as purchasers to engage our health plans to say, health plan, we don't want to pay for errors? Okay, how do we have same signals being addressed from the private purchaser community as being addressed by the public purchaser community? We want to align our efforts with public purchasers. So we need to be supporting changes in payment. We need to be engaging our health plans. And I think that often the provider community will look at the health plan and say, God, you know, why are you doing this crazy stuff? Often it's because of what we are going to our health plans and saying. When we go to Anthem, we go to United, we go to Aetna and say, here's what we want you to be doing for our employees. Here's what we want you to be doing in focusing on these priority areas. And that's a key element that we think we can do, focusing in collaboration with health plans, so there's a broad partnership for change. With that, I'd actually like to wrap up with noting the end point of the P's that we started with at the beginning, of partnership, looking at the roles of purchasers, of providers, of plans, of professionals, and in the end, it is all about patients. And without remembering that for all of us, patients are at the center of what we're doing, we are not going to drive change. And I'd encourage you to read more about the priority partnership goals, and I'd be happy to take a few questions in the time I've got. Thank you very much.
We do have some time for some questions for Mr. Lee, so if you do have a question, we have floor mics throughout the room. If you just want to step forward to ask a question, we'd be glad to entertain them right now. We do have a few minutes.
And introduce yourself if you don't mind.
I'm Dr. Susan Miller. I'm a family physician at the Virginia Commonwealth University Health System. I wonder if your group is going to support a public option in the mix of the healthcare options that are going to be offered.
Okay, so the question was, would employers support the public option in terms of health reform? So, you know, I sort of thought that people would be interested in health reform issues as well as the National Priority Partnership. And I guess I'd do a couple of responses on that, which is employers, the thing that they're looking for is alignment of public and private sectors. And I think that often the discussion of the public plan is one of, well, let's have a Medicare for all, the same plan for everyone, the same set of benefits, et cetera. And I think from an employer perspective, the place we start is we do want to see alignment. So if you're a physician, if you're a hospital, you're getting similar signals, whether it's from a private plan or from Medicare or Medi-Cal. I'll note that the public plan, I think, is actually can serve as a distraction from actually getting big reform to happen. It's, to my mind, one of the big landmines out there, because it becomes such an issue that, in particular, a number of Republicans, but also some Democrats are seen as an ideological issue rather than a practical issue. So some employers support it, some don't. My concern is I think we have a very good opportunity to have national health reform. I give it coin toss, 50% odds. But I think there's a couple landmines. The public plan is one of them. I'd rather work with what we want to get out of a public plan, which is to have aligned signals, fair payment, and a simple system for patients.
Yeah, I'm Chal Nunn. I'm the Chief Medical Officer of Central Health. You're from the West Coast, where you've had a lot of experience with capitated payments. I wanted you to make a comment about the experience on the West Coast with that, and if that type of payment reform would get us a little closer to many of the goals that you've espoused today.
Great question. Thank you very much. One of the things that I've learned about being from California but spending a lot of time around the country is, first, there is no one-size-fits-all. California does have a lot of experience with capitated payments, where you're giving a global payment to either a health plan or often a medical group to take responsibility for a patient. That said, what we've seen in California is a lot of well-integrated delivery systems, not just Kaiser, but medical groups that have an incentive to actually keep someone from being readmitted, that have an incentive to promote wellness and prevention. And I think when we look at the payment systems we have today, I don't think there's a linear point of fee-for-service bad, capitation good, and we're migrating there. I do think we have to be at a payment system that gets away from only incenting volume. And I think we need to be looking at a mixed payment system that will have bundled payments for episodes, which you could call mini capitation, that should have in all elements a way that gives feedback and rewards for better performance. Right now, fee-for-service doesn't do it. So we've seen, again, in California, a lot of success with capitation, driving better coordination, driving a focus on wellness. But it also, we've seen when we embarked on it 15 years ago, some medical groups that couldn't manage it, that couldn't handle the risk. And I think we need to look at, as we embark on changing payment systems, have a glide path so small physician practices can be engaged as well as large systems.
Yes, Siobhan Donovan. I'm an OBGYN in the area, and I'm on the board for MSV and VBCH. And I wanted to take us back just one step and comment and get some more detail on the C-section rate. I can't help with my background that being a stumbling block for me. And I'm curious about what the C-section rate should be, number one. And number two, this reference to elective preterm cesareans. I know that I am on my patient safety committee. I'm involved with the perinatal safety initiative. And we have seen market-wide standards that have brought into line very much an advocacy for term-only deliveries. And I really don't see, elective C-section seems to be a really hot topic, but I really don't see it evident in clinical practice. So I think that assuming that the C-section rate is associated with elective rates concerns me, and I wanted to challenge that because I want to advocate for the physician community.
Yeah, I'm not going to say what the right rate should be. And this is one of the things, though, that by having better evidence and better engaged studies, I think we should be able to identify what a normative right rate, Dr. Ramley may have a number, but is the issue, though, of identifying right rate is something that should engage the physician community, engage the patient community. And one of the things I think we've seen too often is, and again, I'm a data-oriented guy, the question of how much is elective C-section driving these rates? It's a question we should be able to find out and know the answer to. But part of what you're flagging to me is it's not just about the physician. It is very much about the patient. and it needs to be engaging that patient in the right care for her. And I want to come back to that first priority, which is patient engagement, is we should never be driving to a rate when it comes to one patient. For that one patient, it should be giving her the information about what does a C-section mean to you? What does it mean for the risks to your baby? What does it mean for where you are in terms of the number of children, et cetera? So being patient-centered is what I'd come to more than the issue of overuse for C-section, is let's make sure patients are engaged in that decision.
Well, and living that every day, I'm concerned that we're suggesting that the C-section rate is too high. And so I do think that's a good point. And contrary to my practice of advocating for elective C-sections, because I do not, there's some interesting data in the OBGYN literature about elective C-section being the safest delivery for a mother and very economically feasible. So it's an interesting and controversial time for us.
Well, and I'd like to add, you just did exactly what I was hoping my kind of wetting the whistle with just a few slides would do, is we have a statewide group of OBGYNs and pediatricians talking about, I don't know what the right C-section rate is, and I don't know that anybody ever will know what the right rate is. I do know that in our state, our premature rates have gone up in the last 10 years from around 8% to around 10%. And that rate, and I didn't bring all those slides today because of the interest of time, has not gone up in the extremely premature. It's gone up in the 34 weeks and above. And as we start to parse out that data, most of those that we're looking at were not spontaneous deliveries of babies in 34 weeks and above. So we're really just now starting to really look at all of this, and I congratulate, I'm sure you're doing it with your group, a lot of OB groups around the state are very aggressively trying to make sure they have thoughtful guidelines in place about when to induce, when to do an elective C-section, and that's what we're seeing, I think, will really help us figure out, with those guidelines in place and people using them, where should we be? Because there isn't a magic number anywhere, and it's different for every mom, every situation, but just making sure that, like everything else we do, we arm our clinicians with data that they can use to help have that discussion with a family. I think that's probably very important.
And focus on the quality of outcome and the quality of experience instead of statistics and numbers.
Right. We're going to take two last questions over here, and then we need to move on. Please.
Bob Kramer, Norfolk Southern Corporation. Peter, the partnership obviously represents most of the stakeholders we've already talked about, and I would be interested in knowing what the takeaways were by the non-provider stakeholders from the providers in your talks and your discussions. What did you all learn in those kind of conversations from the provider community in the partnership?
Well, I think a couple things. That's a great question. The main takeaway really was the importance of the dialogue itself, and not, employers will often start from a perspective of, boy, costs are running crazy, this is absurd, and listening to the provider community in terms of the challenges and how they're actually trying to address the issues of appropriate care, et cetera, is the most important one. So I'd actually just note that the fact of listening and engagement, which is something you noted in your opening remarks, was the most important piece. One last comment, I know we need to move on then.
Have a comment more than a question. I know we're at our time limit. Peter, thanks for your comments. Thanks for sharing with us your work with the partnership. We know it's 28 organizations, and you've been involved with this a lot in the past couple of years. Our employers ask how can they become involved more in supporting the priorities. And I just wanted to comment that we did make available 200 copies of this publication, the National Priorities and Goals, for you to pick up. It's outside the door if you'd like to take home a copy. I think to start off just by reading the publication. And the coalition sees themselves as a collaborative of multi-stakeholders, and we would certainly like to continue the discussion. And thank you for being here.
Great. Thank you, Barbara. Thank you very much.